And so is this kind of testing actually going to increase that burden? There's also been comments about the potential inequality. One, because you have to have resources to access this kind of testing. You have to have at least, $400 or $500, access to a computer, be savvy enough to actually order the test, and all of those things. And so there could be a level of inequality about that. And the other inequality currently, or disparity, is that most of the testing, the bulk of the testing for genetics generally, is done in European populations. And so in our study, we have, I'll show you in a moment, a high percentage, 62% of the people in our pilot study, so small numbers, have been African American. So when we get results back, how do we make sense of that? Because they're being compared to a European population for their disease risks. And so there is certainly right now disparity and inequality about the comparison populations. So the research study that we're in the midst of conducting, that I'm the PI for, is primary care patients' views, attitudes, and decision-making regarding direct-to-consumer genome scans. And that is a pilot study with LUHS patients. We recruited them out of the waiting room in the primary care clinic, and we specifically were looking at two different phases. Right, we're looking at what are your views, what are their views about this, their attitudes, and how do they make decisions about direct-to-consumer genome scans. The first phase, which we've completed, involved four focus groups, and you'll see that they were about 8 to 10 people each, and we had 62% were African American, 69% were female, which is typical. Women are more likely to come to a discussion group, although we did have a reasonable percentage of men. And the mean age was 52. We are currently in the middle of phase 2 here, where out of the focus groups we recruited up to 20 people. So we've recruited 16 so far to take one of the tests from one of the companies, this 23andMe test, and that's a whole genome scan. And it comes back and it gives information in all of those different categories that we talked about. And we've had 6 results back so far. So some of the themes that have come up, and again, we're just beginning the data analysis right in the middle of all of that. Some of the themes from participants from both, primarily the focus groups, but also from the second phase, where we're interviewing people 3 times. So we're interviewing them at the time where they consent to testing, when they get their results back, and then 3 months later for follow-up. They talk about very strong notion of advantages to testing. Knowledge. We've heard people say knowledge is power. It's better to know than not to know. I'd rather know whether I'm going to get this or that, or I have a family history of X, heart disease, cancer, you name diabetes, you name it. And so I'd rather know than not know, because maybe I can do something about it. And they definitely are linking those things. Having this knowledge from this kind of genetic testing might give me information that I can do something about. Prevention, right? So I can maybe do something. I can take control. I can change my lifestyle. I can talk to my doctor, do something that will help prevent one of these conditions or diseases. The other area, which again was very strong, was I want to know if I'm likely to pass it on. So if I'm going to pass it on to my children. Sometimes it's about the other family members, might have something or might also be at risk for something, and I could pass on that information to them. But certainly about their children. And also people were very interested when the idea in the first focus group, the notion of testing your children through one of these direct-to-consumer genetic tests came up, and a very strong desire to do that, which kind of surprised us as the researchers. Certainly that goes against professional guidelines. You wouldn't generally test a person under 18 for conditions that aren't necessarily likely to affect them, or they're not going to be able to do anything about until they're 18 and they can make that decision for themselves. So there was a lot of discussion about, I'd rather know what's likely to happen with my child so I can keep an eye out, again, knowing and prevention, those themes coming back, but for this third party, the child. And we also had some people talk about, well, what if you had adopted children? You don't know their medical history. And so this would give you some kind of information on which to base decisions, or at least to keep an eye out and see what they might be likely to develop. So that was one area. The other area was disadvantages. And there definitely were pros and cons. People definitely had a whole range of views. Looking at ethical issues, we heard the word eugenics, that people might use this information for eugenics to make decisions, not just about reproductive decisions, but which children you'd want or not want, which characteristics you'd want and not want. That was not strongly threaded throughout all 4 discussion groups, focus groups, but we did hear that. Certainly issues around privacy. What's going to happen to this information? How secure is it? Who might have access to it? Not just from the kind of big brother government end, but also all the way down to mail delivery. How do these results come to you? Do they come to your house? Do they come in the mail? What happens if they get lost? Who can hack into a computer? So the whole range of privacy questions, as well as what will be done with these results. So is that just up to me? Do I talk to my doctor? What happens if I talk to my doctor? What happens about insurance? Could I be denied coverage or a job? All of those different things people talked about, as well as accuracy of the tests themselves. Now this is in contrast to, there are very limited empirical studies. There are a number of things in process, but very few published yet in this specific area. And this is one that had asked some similar questions to the ones that we're asking, although their population was very different. So this was a study published in 2008 by Amy McGuire and some of her colleagues down at Baylor. And they looked at social networkers. So they looked at Facebook users, and they selected a specific population, so they make no claims about it being representative population. But they looked at users of personal genome testing, so this kind of genetic testing. You can see they surveyed 1,087 people via an internet survey through Facebook users. You had to be a Facebook user. And not surprisingly, 83% were Caucasian, 73% were female, and 59% they called them highly educated, so they had a BA or above. That would be the profile of Facebook users, I take it. So that is not surprising. What's interesting here is that 47% had heard of personal genome testing. Perhaps, again, not surprising, they're computer savvy, they're social networkers, they're using that kind of technology. Many of the companies will actually offer you a social networking option. So if I come up with a particular variant in my genetic information, I can go looking for other people who have that variant, and we can network socially around that variant. So it's a new twist on the Facebook take. And of this population, so 6% of this, and they hypothesized that this was a population that was more likely to have used this technology. So again, not necessarily representative of the general public, but even so, 6% had used it. 64% would have considered using this technology of the personal genetic testing, and 30% said they wouldn't. So I thought these would be interesting for this particular group because they asked specifically about expectations of physicians around this kind of personal genome testing. Now, a number of this population, this group, their view of personal genome testing, they viewed it as information about a medical diagnosis, right? So we talked about how, the professional societies and other groups are saying this isn't diagnostic, this is predictive testing, and largely, and we're not quite sure about the accuracy, validity, reliability of the tests. So it's interesting that in contrast, people who were asked about this are viewing this to some extent as medical diagnosis. Now, it differs, right? So they had 3 categories. They broke down their results into 3 categories. So 38% of people who said they would use it, this kind of genetic testing thought that this would be medical information diagnosis, 23% of those who wouldn't use it, and 60% who have used it, so 60% of that 6%, said that they viewed it in some way as a medical diagnosis. The second category here, would you ask your physician for help in interpreting these results? Very obvious question. We all are interested to know the answer to that. 78% of those who said they would use it said yes, they would, and 53% of those who had used it, the genetic testing, said yes, they would ask their physician or had asked. So this group had already talked to their physicians. And overall, look at that, 61% of all the respondents, so the 1,087, agreed that physicians have a professional obligation to help individuals understand PGT results. On the other hand, they go on to say that a number of people recognize that physicians may not have all the tools or the training to do that, but yet the expectation is there. So there's a dichotomy, a tension in that area. So some of the practical issues, just to highlight here, one is the genetic knowledge and training that varying groups of physicians have in genetics. And how are you all going to be able to respond when people come and ask you questions about this, what it means, which kind of test it is, what they should do on the basis of the results, if anything, right? So the interpretation of the results as well. So questions about how do you cope with that, how do you deal with that, what do you say when patients turn up with this kind of information. Certainly resource allocation questions around time, time spent to go over the information yourself, time to understand it, time to explain it, costs, and then what happens if a patient comes in and talks to you about this? Do you put it in their medical chart? Do you note it that you had a discussion about it? So what happens to that information? And some of that may depend on what they have found through this kind of testing. And again, then do you then look at, well, I want to run my own tests and find out what happens. And of course, there are costs associated with that. And referrals. Or do I need to refer somebody to a genetic specialist or genetic counselor, somebody else who knows more about this specific area than I do? Always important to remember that any kind of genetic information has to be taken in the context of family history, medical history, as well as lifestyle, environment. All of those choices impact the outcomes there. Just want to say thank you to the research team. Two of them are here today. Sarah Cherney and Tanya Saunders are here today, and the other folks who have been helping conduct this research, and I'm happy to take questions.